First, thank you all for attending. We can bring all the speakers, the best speakers in the world, but without your attendance, the conference is unsuccessful. So thank you all for attending. I want to again re-emphasize my thanks to all the vendors for their support, and especially to Shasta Regional Medical Center. The support that I get from the hospital is incredible, and we really, in this day and age, are unable to support bringing speakers and the quality of the conference that we have without the support of the hospital. So I would be honored if Cindy Gordon is here, and if Cindy can come up and say a few words, I'll be very grateful. Cindy is the CEO at the hospital at Shasta Regional. Thanks.
Thank you, Dr. Khan. Good afternoon. On behalf of Dr. Reddy and Shasta Regional Medical Center, I'd like to thank Dr. Khan and his staff for putting together such a fabulous symposium. I think one of the great appeals of this event is not only the venue, but the fact that we get to hear world-class speakers in our own backyard. These kind of events take a lot of detail and a lot of planning, and we'd like to really acknowledge you and your staff, Dr. Khan, and thank you.
Thank you. Thank you, Cindy, very much. Thank you for all your personal support and the support of the hospital. And I also want to thank the Gaia Hotel. They've been very accommodating. Elizabeth. And of course, we are a small office. We don't have any event coordinators. I want to thank Sabina and thank my staff, Linda, Debbie, everybody for all the work that they do. Okay. Now, there's been a lot of controversy, and I prepared the question and answer format. I submitted these questions to a couple of my professors because I knew there was some controversy over it. They looked at it, and Dr. Amsterdam encouraged me to go ahead and encourage that we use the Framingham risk score until we really get adept with the new guidelines. If I can have my slides. Okay. Now, this is going to be interactive. Disclosures are none, no interest. And I will start with this ancient Chinese proverb that inferior doctors treat the full-blown disease, mediocre doctors treat disease before evident, superior doctors prevent disease. So what you do is very, very important on an everyday basis, far more important than what we do as specialists. You're all going to need your cell phones for this interactive session. This is my good friend Dave Nelson, who wanted this to be Jeopardy, took this photograph and superimposed it on Electrobax and thought that it would be great if all of this is done in a Jeopardy format.
This is Jeopardy!
But what he did is, when you have all these different Jeopardy questions, I'll come to that in a second, but we're going to need, this was supposed to be a test with some answers. Okay, so this is how we're going to do it. You take your cell phone, and you're going to text and send the text message. So if you think the food at the Gaia Hotel was okay, you'll text it to 111164. If the food was good, you send a text to 115611. If it was very good, it's 465201. Delicious, 465202. So let's see if we can
The code that they're going to want to text to is 22333 at the top left of the screen. So that's where you're going to want to send it to.
Well, I'm glad we got a text.
If your answer is
so how are we going to do this? Sorry, repeat that.
Yeah, so the 22333 in the top left corner there, you'll see that code. That's where you're going to be sending all these to. And then if your answer is, say, your answer is A, then you would text the 111164 to that other number. So
Everyone younger than you knows how to do it.
the 22333 is going to remain constant through the entire.
I have no idea what he's saying. If you guys know it, that's great. Is it clear? Because all the answers, so we get live feedback here. Okay, so everybody felt that the food was delicious. So I'll just put in a word for the chef. The chef, the Gaia Hotel changed hands. The chef was recruited from Chicago. He usually cooks for every year at the Masters, for Jack Nicklaus this year, Tiger Woods last year. So they brought the chef over to try and make a difference. And I hope the food was good. Okay. All right. And what he made me do was, I actually had to redesign the questions I had. Some in all these different categories. I had to make some questions that were easier, that were just 100 points, and the more difficult questions were 500 points. And so let's see, we'll start with a relatively straightforward question. Let's see now, if I can get this mouse working. I can't seem to work the mouse. I stood up here and tested everything. Can you click on 100 there? This mouse is... Can you see the mouse? Oh, okay. I can't see it on my screen. All right. First question. Okay. A 63-year-old obese woman who smokes has a history of hypertension, elevated cholesterol, and depression. She is concerned about her risk of having a heart attack because her father died of a myocardial infarction at age 54. Which of the following is associated with the greatest risk of an acute myocardial infarction in this patient? And so those are your answers, and the choice is dyslipidemia. This comes from the very large InterHeart study. The InterHeart study was a study of 15,000 patients. They took 15,000 patients who presented to the CCU or ICU with their first heart attack and compared it to 15,000 sex and age-matched controls. And what they found, now this was 52 countries. The questionnaire was in 11 languages across Australia, Asia, South and North America, and the United States. And what they found, that no matter which part of the world you're in, your risk factor for having a heart attack is about the same. And what they showed, that these were the 9 risk factors that led to 90% of all heart attacks. And when you take it on an individual basis, dyslipidemia and cigarette smoking accounted for 2/3 of all heart attacks. Dyslipidemia was associated with a 4-fold increase, smoking with a 3-fold increase. And if patients smoked and came in with a heart attack, their risk of dying was increased 2 to 3-fold. And patients who quit smoking for about 2 years diminished that risk. And so you can see how important that is. They also found that there was no safe level of smoking, and there was no plateau. The more you smoked, the greater your risk. The more you smoked, the greater your risk. The less you smoked, the less your risk. Even smoking 1 to 4 cigarettes. You know, when we prescribed aspirin for primary prevention, it reduces your risk about 20%. Smoking 1 to 4 cigarettes negates that benefit of aspirin, And smoking 1 to 4%, 1 to 4 cigarettes diminishes the efficacy of statins by about 75%. This is very important. 6,000 children attempt cigarette smoking every single day, and 3,000 children become regular smokers each and every day. So very, very important. What they also found, that obesity, it was abdominal obesity that correlated with risk. So and that hip to waist ratio should really be more of a predictor for cardiovascular risk than the patient's BMI. Oh, I screwed up. Can you go back one slide, please? To my last slide. If you can't, I'll just go forward. Next. These are teething problems when you do all this fancy stuff, you see. Next. I'm sorry, I'm going to try not to do this again. Okay. We'll go to question number. Now this is where the controversy starts, but we'll go ahead. A 56-year-old male discusses with you his risk of having a heart attack. His father had a heart attack at age 50, and his brother underwent stenting at age 49. He takes losartan for hypertension, feels well, runs 3 to 4 miles per day. His physical exam is given, his lipid profile is given. What is this patient's cardiovascular risk, and would you recommend a statin? Pretty good for not having the Framingham risk score in front of you. So basically the patient is intermediate risk. And this is where you use the Framingham risk score. It's a simple score, it's easy to calculate, it's available on your iPhone, and you can just Google it. Comes up Framingham risk score, there's a few risk factors. I entered this patient's data in, and we get a Framingham risk score of 12%. Now, if somebody's Framingham risk score is less than 10%, they're very low risk. If somebody's Framingham risk score is 10 to 20%, they're intermediate risk. And if somebody's Framingham risk score is more than 20%, that patient is a high risk. So you heard earlier today about high sensitivity CRP and calcium scoring. If somebody's Framingham risk score is less than 10%, that patient is low risk. We don't have to do a high sensitivity CRP. It's a waste of money. He's low risk. We don't have to get a calcium score because the patient is low risk. If you take a patient whose calcium score is more than 20, that patient is high risk. We know that. We know the patient needs a statin, and there's no need to do a high sensitivity CRP or a calcium score. It is only for the intermediate risk patient where a calcium score or a high sensitivity CRP is of benefit. Okay. A 65-year-old man sees you for cardiac risk assessment. He has no symptoms, exercises regularly, does not smoke, and takes no medication. There's no family history of coronary artery disease. Physical exam is given, his blood pressure is a little elevated, and they give you his Framingham score. His Framingham score is 15%. That's intermediate risk. He is extremely reluctant to take an aspirin or a statin. What is your recommendation for this patient? Respect his reluctance to take the aspirin and statin. Recommend that he take the aspirin and statin since he is 15%. Stress test first, cardiac CRP, CT angiography. So of 40 people that responded, 41 say he should take his aspirin and statin, cardiac CRP. Now, so I want to re-emphasize this. Less than 10%, we said you do not need a CRP. More than 20% is high risk, you do not need a CRP. One of the intermediate risk patient, if you do a CRP, it can reclassify up to 30% of patients into low risk or high risk. So if you take that Framingham intermediate risk patient and you do a CRP, if it comes low, you can say, okay, you do not need aspirin or a statin. If the CRP comes back high, you say you really should initiate it, or if they're high risk or they're already on it, then you can intensify it. So you can see where the CRP is beneficial. If in the intermediate risk, they don't want to take a statin, you can do the cardiac CRP and you can reclassify the patient into high or low risk. I think that was my third question, wasn't that? A reduction in daily salt intake by 2 grams a day would leave an average to which of the following reductions in systolic blood pressure? Oh, it didn't work. All right, 2 millimeters. They got the answer. So let's talk about this for a second. You know, we heard earlier that somebody said use salt as an in, but I would still propose use sodium, because when you read all the nutritional labels, sodium is mentioned. So the normal sodium consumption should be about 2,300 milligrams or about 6 grams. 1 gram is 400 milligrams of sodium. But we need to, patients, especially patients with hypertension or heart failure, your sodium intake should be about 1,500 milligrams. So for every gram of sodium you reduce, or 400 milligrams, you'll drop your blood pressure by 1 millimeters of mercury. So 2 grams, you drop your blood pressure by 2 millimeters of mercury. Now that may appear as very small, but 2 millimeters over 10 years globally will avert 10 million deaths. 2 millimeters will reduce your ischemic heart disease risk 7%. And 2 millimeters will reduce your risk of dying from stroke by 10%. So it is very significant. And also, patients who really comply, or patients with high blood pressure, they will actually get a reduction of about 5 to 10 millimeters in their blood pressure. And again, weight loss, about 10 pounds could lower your blood pressure almost 10 millimeters of mercury. Definitely at least 5 millimeters of mercury. So this is the current guidelines for hypertension. It should be about 1,500 milligrams of sodium.
Before you go to next slide, I have something to say here, because patients, everybody needs to understand this clearly, that you're talking about hypertension and not patients with systolic LV dysfunction.
Correct.
Because, you know, I have patients who are on large doses of diuretics from outside, or who have PCPs and who have orthostatic hypotension, sodium restriction. Nobody can increase their beta blockers or ACE inhibitors because of that. And so,
Well taken point. Hypertension. That's why I said for hypertension.
I just want to make sure that
All right. So here's a trick question. This is 500 points. So let's see if you can get this. A 45-year-old woman with a Framingham risk score of 2% and a family history of premature coronary heart disease presents for risk assessment. A referral for calcium score is appropriate, inappropriate, uncertain appropriateness, or unknown appropriateness. The calcium score, the patient's Framingham risk score is 2%. Okay. We said when your Framingham risk score is less than 10%, you're very low risk. You do not need a cardiac CRP or a calcium score. But there's one caveat to that. If you have a premature family history of coronary artery disease, you can use a calcium score or high sensitivity CRP. That is the only exception. And again, family history was defined. It's not your uncles or grandfathers. It is men. It is mother, brother, father, sister, and children. Your father or your brother or your children for men less than 55 and women less than 65. Immediate family history. Okay. Question, second column. 100 points was too easy in question, so I'll go to 200 in the interest of time. A 64-year-old woman with a history of hypertension, diabetes, and coronary artery disease had a stent placed to the LAD 6 months ago. Her BMI is 34, waist circumference is 37 inches, and she walks on a treadmill 30 minutes daily. She has made several attempts at losing weight over the past year, but has been unsuccessful. Hemoglobin A1C is 7.5. Which of the following is the appropriate recommendation for this patient? Bariatric surgery, phentermine. She should increase her exercise goal to 60 minutes. Approximate initial goal of weight loss is 20 pounds over the next 3 months. Okay, not a lot of responses, obviously. There we go. Okay, and the answer is, all right, bariatric surgery is recommended for a body mass index of greater than 40. The patients whose body mass index is more than 35, you can also recommend bariatric surgery if they have a lot of comorbidities like this patient, if they had stent placement, if they have diabetes, if they have hypertension. So if they're very high risk, a body mass index of more than 35, but this patient is 34. Phentermine can be used short-term for about 12 weeks, but not in patients with known cardiovascular disease, and she had a stent placed. And the initial goal of weight loss should be about 10%, over 6 months, not over 3 months. That's the current guidelines. LBI guidelines is that you should lose about 10% of your body weight loss over 6 months. Exercise guidelines, about 30 minutes a day to prevent chronic disease, 45 to 60 minutes a day to prevent weight gain. So if you don't want to gain, 45 to 60 minutes and 60 to 90 minutes a day for weight loss. So she needs to increase her exercise. That's the current guidelines. Daily double. Music didn't come on. All right. A 58-year-old with a history of an MI 3 years ago is evaluated for chest pain of 3 months duration. He describes it as a substernal chest pressure with walking 1 to 2 blocks, relieved with rest or sublingual nitroglycerin. The patient is on aspirin, metoprolol, a statin, lisinopril, isosobide, blood pressure is 140/85, pulse is 80. Which of the following is the most appropriate management? So this patient clearly has unstable angina. That is excellent. Increase metoprolol. So when somebody has angina, you've got to get the heart rate down to about 55 to 60 beats per minute. That's when you say the patient now has failed beta blocker therapy if they're still having chest pain. For those of you who do stress tests, if you look at when they develop their angina and you look at the heart rate at that time and reduce it to 75% of that, you will significantly relieve their angina. So beta blockers. What about our other choices? Diltiazem is recommended for angina. However, it is a negative inotrope, so be careful in patients who have a diminished ejection fraction. Ranolazine or Ranexa is now in the guidelines as first-line therapy. So it's equivalent to beta blockers. We still all use beta blockers first, but it is first line or now even as add-on therapy. And one of the advantages over isosobide, for example, is patients who are taking phosphodiesterase inhibitors, Viagra, Cialis, etc. The interaction with nitrates, with Ranexa, you don't have that interaction. So it's equivalent and recommended. External counterpulsation, these are pneumatic cuffs that are placed on the legs that they inflate and deflate. They work like an intra-aortic balloon pump. When they inflate, during diastole, they push blood into the coronaries, improve collateral circulation, and when they deflate, they suck blood out of the ventricle and unload the heart. But there's only one indication, only one, and that is class 3 angina. Class 3 angina. So for patients where you have no options, that you cannot stent them, they don't have options for bypass surgery, they may have had 2 or 3 surgeries in the past, you've maximized their medication, and they're still having angina, that is the patient that you will recommend external counterpulsation. Okay, which of the following is not considered a coronary heart disease risk equivalent? Okay, nobody's responded. Obviously, I responded. There's a lot of controversy over this. You can see. Didn't record. Okay, diabetes. So everybody was paying attention to Dr. Amsterdam's lecture. But that's not the answer I was looking for. Oh. Can you go back one? The answer is Framingham risk score of 20%. Remember, it is Framingham risk score of greater than 20%. Now, the American Diabetes Association still considers diabetes as a coronary disease equivalent. It is only now new that the American Heart Association has dropped it as a risk factor. But the point is, these patients are still very high risk. Patients with peripheral arterial disease, abdominal aneurysm, they're equivalent to having had, when we say coronary risk equivalent, they're equivalent to having had a heart attack in the past. They're the same. They should be aggressively treated. So anybody with peripheral arterial disease, carotid disease more than 50%, abdominal aneurysms, these patients, and a Framingham risk score of more than 20% are considered very high risk. This is obviously not working as well as I would. This is also controversial. 43-year-old with type 2 diabetes, whose father was on dialysis, died of a heart attack at age 50. He's concerned about his future risk. He feels well, exercises regularly, does not smoke. What is the patient's risk of having a heart attack by age 50? 43-year-old. I'm scared to press the next click, so. Dave, thanks very much. I love you, man. Okay, at least I'm not putting you to sleep. All right, the patient's risk of having a heart attack is 20%. And this is where was talking about the East-West study to Dr. Amsterdam earlier. Go forward. Okay. The American College of Cardiology and American Diabetes Association took about 2,000 diabetic patients, and this was in 2009, and they conducted a survey. And the survey asked patients, what are you concerned about having diabetes? And you can see here that about two-thirds of patients said they were concerned about blindness. Significant number of patients said they were worried about an amputation. Small number of patients were worried about an MI or stroke. And when they were specifically asked, are you worried about a heart attack or stroke? And you can see most patients said no, they're not concerned about a heart attack or stroke. And when you look at the UK PDS study over 10 years on the outcomes of diabetic patients, and you look at the outcomes after 10 years, blindness, only 2 to 3%. Renal disease, renal failure, 2 to 3%. Amputation, very small risk. And you look at their risk of a heart attack and stroke, very significant. So it tells us there's still a lot of education we need to do in the diabetic population to tell them about their risk of cardiovascular disease. This is the study I was referring to. Now, it may have been small. Dr. Amsterdam said it was a small study. This was 4,000 patients. And that the 4S study on simvastatin, that was a landmark study, was 4,444 patients. So this was a significant number of diabetic patients. On your left, you have no diabetes, and on your right, diabetes. If you have a diabetic who's never had an MI, a non-diabetic who's never had an MI, your risk of having a heart attack over the next 7 years is 2 to 3%. If you take a non-diabetic who's had a heart attack, the risk is about 19%. Now let's look at diabetics. A diabetic who's never had a heart attack, the risk of a heart attack is 20%. And this is where the notion came on, and this is why the American Diabetes Association recognizes it as a coronary risk equivalent, because they're about the same. And if you look at a diabetic that's already had a heart attack, look at their risk of a second heart attack. Very, very significant. So it is considered by the American Diabetes Association as a coronary risk disease equivalent. Okay. A 35-year-old woman follows up for heart failure. Let me skip this. This is an easy one. This is heart failure. We discussed this as heart failure, so in the interest of time. Okay. 45-year-old man was seen at a health fair 2 weeks ago and was told that his blood pressure was 174/96. His blood pressure in the office is 168/92. His BMI is 23. His EKG reveals LVH. Which of the following would you recommend? Therapeutic lifestyle changes for 6 months, start an ACE, start spironolactone, start a beta blocker, start a combination agent. So you were all paying attention to Dr. Wright's lecture on combination therapy. Therapeutic lifestyle changes, especially in somebody who has target organ damage like left ventricular hypertrophy, should never be more than 3 months. And follow the rule of 10-5. Dr. Mende mentioned it, just touched on it. If you use an antihypertensive agent, you're going to get about a 10 millimeter reduction in your systolic blood pressure and about a 5 millimeter reduction in your diastolic blood pressure. So if you use the rule of 10s, if this patient comes in with a blood pressure of 168 and you want to reduce it to less than 140, that's 28 points. You're never going to get anywhere with one drug. You're going to need 2 or more drugs. So if you start the patient on lisinopril 10 milligrams and you get your 10 millimeter reduction, going to 20 milligrams is only going to give you another 3 to 4 points. You're never going to get it, and that is why you need to use combination therapy. So for every antihypertensive, you're going to get about a 10 millimeter reduction. Your first line approach ideally should be an ACE or an ARB. If it's not controlled, you add a calcium channel blocker. And you heard this earlier as well. This was the accomplished trial, 10,000 patients. And by the way, what they didn't mention was that the blood pressure reduction was the same using the ACE calcium combination and the ACE diuretic. The blood pressure reductions were the same, but the outcomes were significantly better in the ACE calcium combination. So there's something to do with some of these agents. And then you add a diuretic or a triple combination. Beta blockers, again, if they have tachycardic, have AFib, have coronary artery disease, and aldosterone antagonists for patients more with resistant hypertension. Okay, 50-year-old male with difficult to control hypertension comes to you for a second opinion because his blood pressure remains high. His BMI is 42, does not smoke, drinks 10 to 12 beers a day. Enalapril, amlodipine, hydrochlorothiazide, atenolol, and clonidine, and his blood pressure remains high. I think this line is absent in your handout. His blood pressure remains high. Which of the following would you recommend? A triple combination first so that he's more compliant. Change hydrochlorothiazide to spironolactone, since this is a better drug for resistant hypertension. Increase clonidine, weight loss, alcohol cessation. Boy, you guys were really paying attention today. Alcohol cessation. I have a patient now in a very prominent position. I can't get him to stop alcohol, and I can't get his blood pressure controlled. This patient is on multiple antihypertensive agents. And you can see that unless he cuts back on his alcohol, it's going to be very difficult. Now, the definition of resistant hypertension, Dr. Mende touched upon, you've got to be on at least 3 drugs at adequate doses or full doses. One of them must be a diuretic before you can say that the patient has resistant hypertension. Obesity is the commonest cause of hypertension, and alcohol consumption is the leading cause of difficult to control blood pressure. So when you see it, think about it. All right. A 64-year-old man with hypertension and type 2 diabetes, but no nephropathy, has a blood pressure of 212 over 116 taken at his 3-month follow-up. Blood pressure readings 3 months ago was 162 over 92, and at that time, enalapril was increased from 20 to 40 milligrams. He has no symptoms. Fundoscopic exam is unremarkable. Urine dipstick is normal. Which of the following is the next most appropriate step in his care? Return in 1 week for a blood pressure check, add amlodipine and see him in 1 to 2 days, give sublingual nifedipine, admit the patient for IV antihypertensive therapy, duplex ultrasound to exclude renal artery stenosis. That's terrific. I see so many patients being sent to the hospital for their blood pressure control. This is the difference between a hypertensive urgency and a hypertensive emergency. If somebody is in heart failure, if somebody is confused or has encephalopathy, if somebody has unstable angina at that time, that's a hypertensive emergency. That patient goes to the hospital. Otherwise, it's a hypertensive urgency, and you can add a medication. Even in the office, when you give the patient, if the blood pressure is very high and you give the patient clonidine, for example, you don't have to wait for it to come down to 120. You just drop it by about 25% over the next few hours. You drop the blood pressure 25% and follow the patients carefully. So they really don't need to be admitted for poorly controlled hypertension. And I think we're here. The benefit of antihypertensive treatment in preventing cardiovascular disease outcomes such as heart attack, stroke, and cardiovascular mortality depends principally on which of the following: reduction in systolic blood pressure, reduction in diastolic blood pressure, the effects of plasma renin, effects of circulating catecholamines, all of the above. Reduction in systolic blood pressure. The meta-analysis of all randomized trials show that your reduction in systolic blood pressure is what correlates with cardiovascular outcomes and deaths. Here's just one of them, the Mr. Fit trial. If you look at the blue bars, these are your diastolic blood pressures going across. And look at the risk of death in these patients. Compare that to the colored bars going up. You can see that your systolic blood pressure correlates most with deaths and outcomes. What is also very important, he just touched upon it, is this taking your blood pressure pills at night. Remember, most cardiovascular events occur in the morning between 6 and 10 in the morning. That's the time you want patients to have optimal blood pressure control. And when you take the medication at night, those patients, if you make them wear a 24-hour ambulatory blood pressure monitor, and if their blood pressure doesn't dip at night by about 25%, we talked about those non-dippers, they are at the highest risk. The next highest risk is systolic blood pressure. Diastolic blood pressure goes down as we get older, and the systolic blood pressure goes up. So you have this big difference called the pulse pressure. After systolic blood pressure, it's this pulse pressure. If this pulse pressure is more than 60, that patient is at significant high risk. So you want to treat the systolic blood pressure. The only time diastolic blood pressure has been shown to be useful is the hypertension optimal trial in diabetic patients, where there was a very big difference even between a diastolic blood pressure of 85 or 80. If you have an elderly patient whose diastolic blood pressure remains high, there's only one condition that you have to think about is thyroid dysfunction. Patients with thyroid dysfunction will usually have an elevated diastolic blood pressure. Okay. A 42-year-old man is being evaluated by you at the request of his wife for occasional shortness of breath. He's not happy being at the office, denies any chest pain, orthopnea, or PND, does admit to being just a little short of breath during his daily activity. Physical exam is unremarkable, no JVP, echo reveals an ejection fraction of 33%. Which of the following do you recommend? Aggressive risk factor modification, start an ACE inhibitor, start an ACE or a beta blocker, ACE, beta blocker, digoxin, ACE, beta blocker, digoxin, and spironolactone. It's always a little challenging when you have an audience like this, a wide variety. Some questions are very easy for some are more difficult. So I hope for those that it's easy, it will just reinforce and they'll bear with me. Okay, terrific. You got it right. Start an ACE inhibitor and a beta blocker. The guidelines recommend that regardless of symptoms, if the ejection fraction is less than 35%, to decrease morbidity and mortality, those patients need to be on an ACE inhibitor and a beta blocker. If the blood pressure is not very high or you're concerned that you might drop the blood pressure, the first drug to start is a beta blocker. After that, you don't increase the dose of the beta blocker. At the next visit, you start the ACE inhibitor. And then gradually up-titrate both of them at the same time to reduce morbidity and mortality. So it is beta blockers. Now, this patient has just a little shortness of breath. We talked about New York Heart Association classification, and that's how you describe patients. So if somebody has an ejection fraction of less than 35% and they're totally asymptomatic, that's class 1. If they have just a little shortness of breath, for example, they can do their usual activity with very little shortness of breath, like this patient, that's class 2. This patient is class 2 heart failure. He's just a little short of breath. If they get significantly short of breath, they can do their activity, but they significantly short of breath, that's class 3. And class 4 is patients who are short of breath with minimal exertion or at rest. That's class 4. Now, what's important about this is that if you look at sudden cardiac death, look at the green in this pie. These are New York Heart Association class 2, like our patient, just a little short of breath. These are the patients that are dropping dead from sudden cardiac death. Also, the class 3 patients may be more short of breath, but it is not heart failure. Heart failure and recurrent heart failure occurs mainly in the class 4 patient. So when these patients come with just a little shortness of breath, we need to treat them seriously, because 40 to 50% of these patients that drop dead were seen within the last month by a physician and not recognized as heart disease or from LV dysfunction. And you know that sudden cardiac death is more common than lung cancer, breast cancer, or AIDS combined. So very, very significant. Oh, this thing is not working as I wanted. A 52-year-old man with a 1-year history of non-ischemic cardiomyopathy is short of breath, walking less than 1 city block or 1 flight of stairs. So this patient is short of breath. This is class 3. Not at rest, but any exertion, this patient is really short of breath. The patient is on Coreg 25 BID, lisinopril, aldactone, digoxin, has normal sinus rhythm. Your handout says non-specific changes. It should be left bundle branch block with a QRS of 155 and an ejection fraction of 25%. Which of the following is the most appropriate treatment option? I won't click on the music just in case. Add Lasix, add an ARB, increase DIG, AICD, BIV pacing. Okay, excellent. Biventricular pacing with, this patient is on optimal treatment. This patient is on ACE inhibitors, beta blockers, digoxin, aldactone, and everything. But this patient has a left bundle branch block. If this patient did not have a left bundle branch block, then all you could do for this patient to prevent sudden cardiac death was put in a defibrillator. Now, if the patient has a wide QRS or a left bundle branch block, if you put a pacemaker or a defibrillator without biventricular pacing, and I'll get into it, you actually can increase mortality. When the patient has a bundle branch block, the 2 ventricles are not squeezing in sync. They're milliseconds apart. So the right ventricle and the left ventricle are not in sync. They're squeezing not simultaneously. And when the right, and if you put a defibrillator or a pacemaker and you pace the right ventricle, all it's doing, it's pushing blood to the left or to the septum. It's not helping pump blood out. It's just pushing blood in these patients, and you can worsen heart failure. So if we can put in a third lead or an LV lead over onto the left ventricle, so biventricular pacing both the right and the left ventricles, now you resync it. And that is why at the bottom here you'll see it's called CRT, cardiac resynchronization therapy, with the D is the defibrillator. So you're resyncing it, and in about 70% of patients you can help improve their shortness of breath, cardiac outcomes, and they have the ability to prevent sudden cardiac death with the defibrillator. Now there are some patients, let's say you have an 85-year-old patient who has recurrent heart failure, and he's on optimal medical therapy, and the patient does not want a defibrillator to be shocked. He says, you know, if I have sudden cardiac death, that's the best way for me to go, and that's understanding, but he keeps coming in with recurrent heart failure. For that patient, we can consider CRT-P. You can still put in biventricular pacing just with a pacemaker. They don't have to have a defibrillator, so that they can still pace and resync the ventricles to hopefully improve their symptoms and prevent hospitalizations for heart failure. Again, all right. A 68-year-old woman complains of heaviness in both calves with exertion. Symptoms relieved after about 5 minutes of rest. Has a history of hypertension, diabetes, hyperlipidemia. She does not smoke. Her ABI is 1.4. Which of the following is the most appropriate diagnostic test to evaluate the patient's leg discomfort? Okay, we didn't touch upon this one earlier. Okay. So most patients say a duplex ultrasound or an exercise ABI. Toe brachial index. This patient's vessels are very, very calcified. This patient is a diabetic, there's medial calcification. It's so calcified that when you inflate the blood pressure cuff, you cannot compress the vessels. So you cannot get an accurate ankle brachial index. It's too high, it's falsely high. So what you do, most ABI machines nowadays will tell you what the toe brachial index is. And if the toe brachial index is less than 0.7, that patient has significant peripheral arterial disease. The other thing you can do is the great toe measurements. So for some reason, the toes don't get calcified. And you can take the systolic blood pressure in the toe and divide that by your brachial pressure, and if it's less than 40%, that patient has significant peripheral arterial disease. If you do an exercise ABI on this patient, it's still calcified. Even after exercise, it's calcified. You won't be able to compress the vessels. When do you do an exercise ABI? If a patient comes in with claudication, and the ankle brachial index is 0.9, but the history really suggests peripheral arterial disease, then you should do an an exercise ABI. And you can simply make the patient stand up on their toes, back on their heels, on their toes, back on their heels 5 or 6 times. The patient will develop some claudication, and you can do an exercise ABI. Or you can make them walk, and then you can repeat the ABI, and you'll get an exercise ABI. And if there's a drop of 20%, that signifies significant peripheral arterial disease. That's where you do the exercise ABI. If you don't have a toe brachial index, then this patient most likely will need an ultrasound. The differential diagnosis of intermittent claudication is from patients with spinal stenosis. Patients with spinal stenosis will have the same symptoms. They walk a distance, they get heaviness or tiredness in the calves, or they may get cramping in the calves or in their buttocks. The difference is patients with PAD will be able to tell you exactly when their symptoms come on. They'll say either half a block. Every time it'll be half a block. Or if it's after 3 blocks, but every time it'll be after 3 blocks. In patients with spinal stenosis, one day they can walk 1 block, one day they can walk 5 blocks, one day it's 3 blocks, so it's varying distances. That's the difference. Also, patients with spinal stenosis usually have to sit to get relief, or they have to stand for a very long time. Patients with peripheral arterial disease, just after standing for a few minutes, will have significant relief, and that's how you differentiate it from your spinal stenosis. Ankle brachial index, even if the patient has no symptoms, will tell you about the patient's future risk of atherosclerotic cardiovascular